Well, thanks for joining us, guys. My name is Ferrante. I am the manager of infusion services at UNC and also a HOPA member. So two of the centers I oversee a few. Two of them are cancer centers. So Rockingham Cancer Center in Eden, North Carolina, and McCreary Cancer Center in Lenoir. So given these centers are in rural communities with underserved populations, medication costs and availability is really a very common discussion for us. And so given this topic really near and dear to my heart, I'm very excited to be discussing redistribution of unused medications. Today, I am joined by a HOPA colleague, Joseph, who is an ambulatory oncology clinical pharmacist specialist at the University of Colorado Health, and George Wang, who is the co-founder of SIRUM, which is a clever little acronym for supporting initiatives to redistribute unused medications. So I can appreciate that. It was a nice name scheme you had there. So if you guys don't mind, I'd say let's do some introductions. I know WebEx or Zoom can be a little bit challenging, so I'll just go ahead and call it right across my screen. So Joe, do you want to tell me a little bit about yourself and maybe how you got into oncology?
Certainly. That could take us a while, so I'll give you the elevator speech version. But as you mentioned a moment ago, I'm Joe Kalis, practice in general oncology pharmacy at UC Health, Colorado Springs, Colorado. Been in practice a little over 12 years now since graduation from pharmacy school. But throughout my journey into healthcare, I found that I really appreciated the scientific aspects of oncology and kind of marrying that with the communication aspects with patients and providers and then others. And I've been really fortunate to integrate a lot of that into the role I've got with UC Health, where based in a physician office, actually see multiple patients a day for counseling and education on the full gamut of oral chemotherapies, IV treatments, and then immunotherapy. But a number of years ago, PGY2 resident of mine, I'll call her out by name because she deserves full credit for this. Becca Rizak, she actually found SIRUM in response to a patient question that we had, and that is what ultimately led us all together today.
Okay, awesome. Very cool. Very cool. And George?
Nice to meet you, Paul and Joe. Really appreciate the opportunity to speak with you all about drug donation and redistribution. I think this will be a fun conversation. Just a little bit of background about myself. I'm one of the co-founders of SIRUM. I'm based out here in California. We started this organization, this nonprofit, about 13, 14 years ago. And our entire mission is to find the surplus available, donatable, usable medicine in the US supply chain, ultimately trying to match that with charitable pharmacies and charitable organizations that then dispense to patients in need wherever they might be in the country.
Yeah, that's wonderful. I think that, there's definitely a huge patient need for something like this, especially in the oncology space. Can you tell me about, was there a specific event or anything that kind of inspired you and your group to found the organization, and maybe even how you got your start in oncology specifically?
Yeah, we started our organization in the early days because we were hearing two types of stories. One, being like someone named Betty, who we learned about. She's a grandmother, recently discharged from a hospital here locally in San Jose. She's on a handful of meds. She has insurance, but one of the meds has an out-of-pocket cost of $250 that she just can't simply afford. And so she was making these terrible choices between food on the table, getting the med that she knows will keep her out of the hospital, and it was placing a burden, obviously, on her family, but also the care team. And at the same time, we were hearing these types of stories of need from patients. We were hearing stories from folks like Dean. So she was one of the very first directors of nurses that we met with at a nursing home here in San Jose also. And every month, she would take all of the surplus medicine from her residents. She had no choice but to destroy them. And she showed us how she'd hunch over a bucket, and all these meds were packaged in blister cards. And so she would take them and she would pop them all out individually, pop, pop, pop. And then she'd take the liquids and she'd pour the liquids in and she'd mix it around into this like fairly disgusting slurry. And she told us she would say, I became a nurse because I wanted to care for people. And so this is so heartbreaking for me to destroy these meds when I know that they're unused, unexpired, they're perfectly usable, and they could go to someone in need. And in fact, when she was telling us the story, she was in fact destroying the same medicine that this lady Betty could have used. And again, these were unexpired, unopened medicine. And so we thought back then, this was a little bit ago, like in the age of 2-day delivery, now we have, hours delivery. We knew that something better could exist for the situation. And so we essentially wanted to build an organization that could leverage technology, match that surplus that was going to be destroyed with the demand from patients like Betty that needed it. And these stories are all just examples of a greater problem and then opportunity within the healthcare system, in the sense that Betty's story is really a story of 1 in 4 in the US that can't afford the meds they need. Dean's story of surplus is really representative of the $11 billion of surplus that's being destroyed every year in the US. And, where does it end up? It's not great. It used to be flushed down the toilet. Hopefully that doesn't happen anymore. But at best now it's being incinerated, which can't be great, as you can imagine, for the environment. And so these stories motivated us. The scale of the problem and the scale of the opportunity motivated us. You mentioned, Paul, just about oncology. So we've grown this work and been doing this work for many years now, and started to think about oncology recently because of a couple of things. One, we obviously knew that the meds for oncology and other specialty drugs are very expensive, very valuable, and the cost for patients themselves can sometimes be so high, right, that they're forgoing treatment or they're going into medical debt. And secondly, we started to get phone calls and emails from patients, from family members asking us, hey, how can we donate these meds? I have a sealed, unexpired bottle of an oral oncolytic. It's worth $1,000, $10,000, and at first SIRUM, our organization, we didn't really do much with this, but the calls kept on coming in. And to be honest, it was hard to turn them away, especially family members that would call us that had lost someone. So we ended up in the last couple of years looking into the laws. Some states specifically allow the donation of medicine from individuals so long as it's unexpired, unused. So we started to do this work. We knew it would be beneficial for the patients that needed access to these expensive meds, but we also started to realize that it was a relief, a solace to the family members. So you wouldn't believe how many times people have called and talked to us, to my team, and said, my grandmother, my mother, she isn't here anymore, but she would have wanted these meds to go to somebody that needs them. And that is something that we're also able to provide for these families to have at least a little bit more closure in the situation.
Yeah, I think it's kind of almost surreal to hear you put numbers to things. I think when we think about stories like Betty, it's all of us probably know that this isn't unique. We could probably think of 10 more scenarios. I remember being in pharmacy school, and they even teach you how to counsel on proper drug disposal and destruction. So it's just common practice. But when you hear $11 billion in surplus and you realize, putting that number on something, I think is really, really impactful. And I think even more so probably in the oncology space. Joe, from your practice, what are you seeing a lot of medications that are a surplus after treatments end, or maybe patients are going through treatment, have scans change their therapy? Can you maybe speak a little bit to what you see on your end?
Absolutely. I think a lot of that, exactly what you're asking, is what brought us all ultimately together today. The stories we hear from George are things that my colleagues and I in our clinics, I think, see every single day, like trying to alleviate some of those concerns. We're using the surplus medications. And what we're seeing there is, it was doing research a number of years ago, and there was I think a paper from 2018 or 2019 that had found that roughly 41% of medications ended up being in surplus or unused. So the challenge I ran into with that was they're looking at just 4 oral oncolytics in that particular limited study. So I think the scope of the problem is a lot broader than what we see in published literature and published data. I think it's where you've got some of that lag between what we're seeing anecdotally in practice and then what's being published. But in terms of the number of changes we're seeing, you really hit the nail on the head. Some folks aren't able to use medication because their cancer progressed. We saw something on a scan. They have to change a dose because of intolerance or side effects or drug interactions, or even they finish therapy and maybe they have missed doses or a refill of a prescription was sent automatically to them and they're not able to use it. There's a lot of contributing factors that go into the overall issue, but having been able to work with an organization like SIRUM has really been able to make it, I think, a much more streamlined process, a streamlined, almost solution, to use that word here, of being able to put these medications to good use. I think we all are familiar with the issues surrounding drug pricing in the country. And I think, harkening back to my days in like undergrad economics, like this is a prime example of a market inefficiency, you could say. But using technology and then people's goodwill and being able to help others, I think, is a great way to find a solution to it.
Yeah, I completely agree, and I think one thing that's really interesting that you'd mentioned and George had mentioned is, as you know, healthcare providers, we definitely want to do well and we want to help patients. But what's interesting, one thing that George said was that the patient specifically said that, you know, they would have wanted this medication to go to somebody else. And so there's this constant outside drive, I think, all around, of people wanting to do better and help others. So I agree with you there, Joe, that is, you know, it's nice to have an organization that, you know, can help facilitate that. I guess, Joe, the other thing I wanted to ask you too is, you'd mentioned some studies, and then maybe just anecdotally, is there any particular medications or disease states that you happen to see this more frequently than others in your practice?
There are, and I think it's another good example of mismatch. Like the disease states and medications we see might more often may not be the most expensive out there. I think it's all relative terms, of course, but I'd say I'll see medications like capecitabine or abemaciclib, palbociclib, and others most commonly, and coming in those unexpired, unopened packages. And then others, perhaps like capecitabine, that'll come in patients' vials they weren't able to finish or had dose changes. Those, I'd say, are the more common numbers-wise that we run into. If we're looking just at costs of medication, then we get into some of the more specific drugs like infigratinib or pemigatinib.
Sure. Okay. And George, can you tell us a little bit more about the process for redistribution of unused medication and kind of how does that work? I think we definitely identified a need between the three of us who spoke very much to a need. Can you maybe tell us a little about the process?
Yeah, you know, at a high level, it's pretty straightforward. You know, we'll work with partners, healthcare organizations, or individuals, people themselves that have the surplus. And essentially, you know, we educate them that, hey, this is what's eligible for donation. And then we help with the logistics and shipping. So then the donations essentially go from their location or their hands to one of our network of community organizations, basically charitable pharmacies or clinics that receive the donations. The folks there, typically a pharmacist then is making a check to make sure that the medicine is safe. Sometimes the physician does this, and then they're dispensing these meds to folks in need. Typically, this is an uninsured patient or an underinsured patient these days that has a valid prescription.
Okay, yeah, so pretty easy and pretty streamlined then. And you guys are facilitating the shipping and the movement of the product?
Yeah, that's right. You know, it's essentially like we're setting up a recycling program, right? And so, like, in a little bit more detail, there's a couple ways in which we can partner. You know, for oncology meds, you know, we'll say one thing is, for many pharmacies and healthcare systems that we work with, it's really about making sure that their patients know that medicine that they have that they no longer need, that's donatable, that donation is an option. So what this means is we're providing some educational materials to these healthcare systems and pharmacists so they can hand it out to their patients, whether it's a flyer or putting up a poster somewhere, that then the individuals will go and onto our website as an example, and then be able to get a shipping label and then make a donation. And on another situation, we'll work with the organizations a little bit more intimately and essentially partner with a pharmacy or a hospital or a nursing home, and work with their medicine that they have in their possession that may be in surplus. This could be because of the normal course of business. Maybe you just have a little bit extra that you're not able to dispense or use, or in some instances, these organizations, hospitals, and health systems will have their own medicine donation program, and they may not be able to use all of that donated medicine, in which case then they can work with us so that we can distribute those meds or help distribute those meds to other potential partners around the country. There, we'll provide boxes, shipping labels, manage the logistics so that those entities can make donations in a streamlined way, and that surplus can be used somewhere in the country that has patients in need.
Great. Thank you for sharing. I think that's really interesting. I mean, I was wondering before you started telling that, how does that connection be made of the patient in need to what you may have to be able to supply? So I think that was a question that I had, on my own, of trying to visualize this process. Joe, you said, I think that you worked with a PGY2 that maybe connected you to SIRUM, or can you tell me a little bit how you got connected with SIRUM, and maybe what your experience has been thus far?
Yeah, absolutely. So I want to say it was back in 2020, 2021 or so. The PGY2 resident I was helping precept and mentor at the time, Becca Rizak, she and I had encountered numerous patients in the course of our days where we're educating and teaching them or having questions come in through our clinics of, what do we do with medication we can't use? And up until that point, guidance had been kind of what we've alluded to so far. Like, here's some safe ways to dispose of it. You can try and take it back to a pharmacy for disposal. I could have accepted it back and taken it for, as George had mentioned, incineration or other processes there. But Becca had really taken the initiative to find another avenue. I'd worked with different charity pharmacies locally in the past, but their scope wasn't broad enough to encompass oncology medications. And being an oncology practice and seeing what we do every day, that was a big need for us. So Becca had really taken that initiative to identify SIRUM and say, hey, what can we do? These guys seem like they're doing exactly what it is we're looking for. We would like to get started ourselves, but really don't have the infrastructure or regulatory expertise to navigate successfully. I'll out myself on the air as being one of those authority impaired people where if you get a response, my answer's always been, well, why? Why can't we donate this? Why can't we put these medications to use? And I'm sure it drove my parents crazy when I was a kid. My son's 9 and asks the same questions now, so I think it's just a long line of Kalis's. But that streak is there, and it's something that I think really dovetails well into this particular issue. Like, we know what the right thing to do is to get these medications used again. But I will say that I'm not the expert in the right way to go about the right thing. It's as George was alluding to at the story with Betty, it's not as simple as, well, Mrs. Smith gave me a prescription yesterday that they can't use anymore, and Mrs. Jones comes in tomorrow and needs the exact same drug and dose. I wish it was that simple, but that's again where I think having that regulatory expertise and infrastructure has made a big difference.
Yeah, that makes me actually think. I was doing a little bit of research before we got started here, and I saw, George, on your facts page on your website, that one of the facts, or the FAQs, I should say, it said, "Is this legal?" And it really made me laugh at first, but then I thought more about it, and I said, you know what? I bet this really is a common question out there, and probably a lot more people are asking, how does this work, and how do you facilitate? Like you said, Joe, is you're not really an expert on the legalities of things. You're a clinical expert. George, can you tell me a little bit more? Kind of how does your organization address some of those regulatory and legal challenges around medication? I know that you mentioned when we first started that oncology was maybe a new frontier, possibly additional issues might have come up thus far.
Yeah, a good question. And, I have to say, as we've done this work for years and years, that question has it has come up more in the past, a little bit less these days, thankfully. That's part of our mission, is to kind of like move the frontier here forward so that it becomes more standard. As we've been doing this work across the country, like not that we plan to become experts in kind of the drug donation law space, but we've essentially become that in a de facto way, mainly because as we've grown and grown our geographic footprint, lawmakers have come to us and asked us for consultation, for advice on how to either write new drug donation laws or how to amend existing drug donation laws. And then we can bring this practical lens of what we've been doing on the ground and what we've operationalized as we've worked with some of the largest programs that exist in the country. And so we've become experts in that sense and helped shape these laws, and probably helped in about 25 or more laws around the country at this point. So we do have a pretty keen understanding about how to both run these programs kind of operationally, but also how to have them fit into the regulatory frameworks that are necessary. We obviously have counsel that helps us do this too, but we, at a general kind of framework for oncology, it's funny, oncology was, these types of meds were some of the very first meds that started the initial drug donation laws around the country. I think they've always had a oncology or cancer patient bent. And as programs and states have evolved their donation laws, they've included more meds. And now almost all states have some sort of law in the books. Some variations, some nuances. In general, we'd say that individuals can donate from just about anywhere in the country, so it's pretty straightforward from an individual standpoint. Institutions have a little bit more regulations that they need to follow. So most of the country, I'd say a little more than half, can donate pretty readily. And then a lot of the rules are actually on the entity that is receiving the medicine. So whether it's the health system that receives the medicine, a free clinic or charitable pharmacy, what are the restrictions that they have? How much from expiration does the med need to be? What types of meds are allowed? And how do they need to be stored? Those are all the nuances of the law are placed on the entity that's receiving the medicine, making sure that they're doing the proper checks before, again, they're dispensing it. None of these meds can be resold. It's always back out to patients in need, again, with a valid prescription.
Okay. Yeah, I could imagine, a lot of issues around it with individual states, hazardous versus non-hazardous items. So you have your USP-based standards and everything else associated. I think that definitely could be challenging. One thing I saw on your website, you guys facilitated around 40,000 donations so far, which I think is pretty incredible. Are you said it was more on the receiving end as far as some of the legal and restrictions. Are you guys able to send to all states, or are there some areas that are excluded? So until you maybe work through additional processes they might have?
Yeah, again, it's a little bit easier for donations, for donor entities or individuals to make donations. Sometimes they can't donate within like a program within their own state, but there are other states that will allow the medicine to come from essentially anywhere in the country. And so there's more flexibility if you're going to try to donate surplus medicine. And then again, on the receiving side, I would say, while most states have a law in place that allows for receiving the medicine, checking it, and then dispensing it, honestly, only about half the states have programs that are operational, meaning that someone's actually doing that work, whether it's a charitable pharmacy or a hospital or a clinic. And then amongst those, I would say there's probably about a dozen states that do this in any kind of robust fashion. And we're obviously keen on trying to see more and more of these programs and support these programs grow deeper in the states that currently are doing this work, and then obviously grow more geographically to, at the end of the day, trying to be able to help patients no matter where they might be across the country.
Yeah, and I wonder if, as you kind of expand your work and do this more and more in areas of the country, if more of the value is seen and what's delivered to patients, if maybe some of those regulations will be, eased or reevaluated, maybe possibly, again, somebody just looking outside in, perhaps some of it's on the books more of just because it's unknown territory, and so it seems to make sense more than, maybe now that we're looking at it, we can kind of readdress what's feasible and what's not in today's world. Joe, so you, being somebody that works with SIRUM thus far and has that connection, how can other healthcare professionals get involved in supporting SIRUM's mission? And maybe you can kind of speak to some of it from a pharmacist standpoint, and how we could be more involved.
Yeah, absolutely. I think the best recommendation I could give anybody watching or listening out there on how to get more involved with SIRUM would be to check out the SIRUM website. That's first how Resident Becca and I came across them. The donation process is actually super straightforward. The steps are there and easy to follow. Generate just a PDF label, and then you can package it up and mail it off if it's a individual donor. So I've provided that information even to patients and their families if they wanted to make the donation themselves. Say in a lot of other cases, it's simpler or maybe sometimes easier, both physically and emotionally, for patients or their families to bring the medications to my clinic. And I've handled or facilitated some of those donations as well. Beyond just checking out the SIRUM website, I'd say don't hesitate to contact SIRUM. Worked with George and a number of his colleagues over the years, just from the initial process of, hey, we identified this need, you guys have been able to fill it. How do we contribute to that? How do we keep going and make this kind of a process where we can help the most patients possible? So from that pharmacist perspective, as long as you've got a way to communicate to your patients that programs like this exist, either through flyers that George had mentioned, I provide it verbally directly in education when I'm counseling somebody. If there's medication you can't use or are not able to use, bring it back to the clinic. I can help with the rest. Sometimes that personal connection has made a difference. Kind of again to what George had alluded to when we first started chatting, I think just for a patient or even their family, knowing that there's a way that even if medication didn't work for them or their loved one, they can still pay it forward to help someone else. I found that to be just almost a relief. Like telling somebody that of, gosh, my spouse passed away. I've got all this medication. Do you know of anything I can do with it? I'm like, actually, I do. Bring in what you've got. I'm happy to sort through it and use what we can. But just seeing that kind of relief wash over their faces has been such a powerful thing to witness. And I think really speaks volumes to the work that's being done out there.
Yeah, I think, when you were talking about the counseling, I think that really resonated. I think that's a really great opportunity right there. You're already face-to-face with the patient, already having conversation. A lot of time when you, in the oncology space with counseling, it's usually not even just the patient. A lot of time they'll bring a loved one, family members come. I've had educations where, luckily we have a large conference room because we needed 7-8 chairs. The aunt was there who was driving to the first appointment, the neighbor came, and so really it's a great opportunity, not just to impact for the patient, but also everybody in that room can really gain and learn. I think I've had a few instances that I can think specifically that patients have brought back medications in years past, and the same thing, you hate to throw it away. You want to do something with it, especially like I'd mentioned before, is the communities that I had worked in, very rural, very underserved. Even things that we think are cheap, like you mentioned, capecitabine or cyclophosph, that might be something that is not a brand name, not maybe a high dollar, but for some of these patients, a $3, $4, $5 payment might be the difference between taking that medication or not. I know, a lot of our patients that are undergoing radiation, for example, just the transportation back and forth on a daily basis is a financial hardship. So I think it's important to remember that any medication, exactly like you said, is bring it back, let you sift through it, let the expert look through it. The impact really can be endless. So I think that's great. Thanks for sharing. And that's a really good tip. And maybe George, if you wouldn't mind, honestly, actually sharing a few flyers or pamphlets, I think that would be really helpful. I would love a copy for myself.
Yeah, absolutely. And it's as much as we can get the word out that programs like this exist, that there is an option, I think the better. And, especially Paul, you're just mentioning that, it obviously for the really high dollar meds, it can make a tremendous difference. But honestly, it can make a tremendous difference, like you said, when it ends up being even generic meds, especially if folks are on more than one, and all of this adds up, right? And people, honestly, we've heard so many stories of just making these hard choices between the med they know they need and food, gas, education, and honestly, it's just not right that folks need to be making those choices.
I had a recent patient, I was educating them on an oral oncolytic, which pertinent to today was what we're discussing. And they had expressed a fear to me that they're like, I know that this is what I need to treat my cancer, but I don't want treating my cancer to bankrupt my family going forward after I'm gone. And just hearing things like that can be incredibly challenging. And I think the broader scope, the broader impact programs for medication donation and being able to use surplus medication can have, the better overall.
Yeah, no, I agree, Joe. I think those are tough conversations to really have, you know what I mean? And it's unfortunate that a patient even needs to be in that mindset to have to make a choice like that. I think, cancer care in itself is already overwhelming enough. You've met with so many different individuals, and now to have the financial burden on top of it, I couldn't imagine. I think it's, we can envision that it would be challenging, but I think until you're in it, it's probably, not something we can really even wrap our heads around. George, you'd kind of mentioned that, a lot of this is newer and kind of getting things kicked off. Where do you see the future for medication redistribution in healthcare, and kind of where would you like to take this?
Yeah, our vision, honestly, is to have donation be the standard across healthcare in the US for individuals, for families, for hospitals, healthcare organizations, all up and down the drug supply chain. Just as we hope, people are recycling, aluminum cans, we believe that any organization or person that has surplus should realize, one, that they can donate, and two, that they know how to do so. The surplus is great. It's 11 billion on estimates, and that can help the millions of people that are going without today. Again, like we said, it's just not right that folks have to make these hard choices between, going into debt, food, rent, and the meds they need. And really, while obviously it helps, these donation programs can help the patients and their families access medications that they may not have been able to afford. It helps also the healthcare system for everybody, in the sense that, we saw a stat not too long ago that said, folks not taking the meds they need cost the healthcare system as a whole. The number was astronomical. It was $400 billion a year because folks aren't taking the meds that they need. And there's ripple effects on that, and not all of that is due to cost, but some of it is due to cost. And so it is not only helping those individuals and their families, but it also is helping the healthcare system for everyone in this country.
Brings to mind.
No, go ahead, Joe.
I was going to say, it brings to mind a phrase I read recently. It was reading through like a book on Stoicism by Marcus Aurelius from back in the Roman days, and there was a quote in there about what's good for the bee is often good for the hive, and vice versa. It's kind of what you're illustrating there, George. Really drives that home.
Yeah, definitely unique to think about. Not just helping the patient, but also the overall impact on the health system. I know, I'm sure Joe is your favorite just as much as mine are insurance. And, I think that the medications that, they've already paid for it, it's already, been handled, it's been processed. So that cost has been applied, and so if we go and throw that medication out and it doesn't go to any good use, then that's just another cost applied to the health system, that really didn't help anybody. So I think that's a really interesting point. I guess on insurance, I wanted to mention or ask you, Joe, specifically. In your clinic, do you see a lot of oral medications tend to be a challenge from an insurance standpoint? I know recently I've experienced a lot of manufacturer assistance that have changed, and some other, I guess, resources you used to have at your disposal that are kind of walking back a little bit. Do you mind speaking to maybe some insurance or some challenges that you faced?
Yeah, absolutely. Because I think it's I think in a lot of pharmacy situations, medication provision situations, insurance is that elephant in the room that we all know is there. And no matter whether a patient's got full coverage, is barely insured, underinsured, or has no insurance, I'm seeing delays and challenges across that whole spectrum. So I think it's easy to envision someone like, okay, they don't have any insurance coverage at all. Maybe they're undocumented. Maybe they're trying to go through the process of qualifying for Medicaid or other state assistance, and it just hasn't happened yet. But I've also seen situations where a patient has coverage and maybe their oral oncolytic is covered at a 20% coinsurance. And I haven't yet met a patient who can cover 20% of $4,000 to $8,000 a month is a recent average that I'd seen of the cost for that. I recently had one of my oncologists state to a patient on hearing that, he's like, yeah, I couldn't cover that, let alone have expecting a patient to. But I think that even in folks who do have oral oncolytic coverage, we are still often running into the need for prior authorizations or I'd say a lot of delays, even in clear FDA indications where things are covered and should be approved. We're still seeing delays getting the medication to a patient. And then if you fast forward to where they might have to change medicines or get a different dose, that whole process and clock starts all over again. So if there's a way to, I'd say, I was going to say appropriate, that's not quite what we want here, but provide that medication to a patient who either is underinsured, doesn't have insurance, or maybe there's just a different mechanism to get them the right drug more efficiently, then I think it's something that would be pretty easy for all of us to get behind.
Yeah, I think, technology as it evolves certainly has aided in a lot of things. I know, AI is all the rage nowadays, right? So, George, is there any innovative models or technology or anything that SIRUM is possibly working on that you might help facilitate getting these medications to patients? Kind of a little bit about what Joe had really just talked about.
Yeah, we're excited. We kind of growing up out of Silicon Valley, we really do try to leverage technology as much as possible to help advance this work. A couple of things I'll throw out there. One is, we think that much more can be done to safely get temperature sensitive medicine donated. I know it's extremely tricky and it's hard, but we believe that it's possible in the sense that the technology itself has gone down in price. And so what I'm thinking here is like the storage containers themselves. I'm thinking about thermometers that can track the temperature within right where the medicine is at the entire time of transit. And so there's ways in which we believe in a safe way that has tight procedures that we can get temperature sensitive medicine donated in certain circumstances. Not every circumstance, but in some. We think that's powerful. We're going to continue to explore that and make sure that we at least are trying to do that type of work. The other way is we have exciting projects in which, as we've been growing these programs around the country, is really thinking about how do we manage the inventory and storage of these meds. While oncology has a small volume, a lot of the medicines being donated today is a much higher volume of kind of like your generic pills and capsules. There, we're leveraging technology to make sure that we can augment staff time and volunteers so that there's some automation in place. We're building out conveyor belts, image capture, computer vision. You can imagine how that can aid the inventorying and record keeping in order for donation programs to know what they have in stock, have that readily available online on a real-time basis, so that if a patient or a prescriber is wondering, hey, does the pharmacy, the charitable pharmacy, have this in stock? Do they need to call, or can they look on the website and see, oh yeah, this particular drug that my patient needs is available. we can send this prescription to that charitable pharmacy instead of another pharmacy that the patient may not ever go to because the price is too high. So there's things like that we really think can be continually built out to make the donation programs themselves more accessible, and then also just essentially have better data for everyone to know where the meds are and how much is available.
That would be incredible, like a drug donation supermarket. That's fantastic. I think that would be something certainly used. I'm sure Joe would be shopping in his clinic quite regularly.
Every day. There's always a need for something somewhere.
Yeah, no, that's awesome. I do want to be conscious of everybody's time, so I want to make sure that just to circle back to a few items, George, just so everyone is clear, are you guys currently doing donations for only oral medication? I know you mentioned some temperature sensitive. Do you guys do room temperature injectables, IV meds? What kind of medications are donatable?
Great question. So the first thing off the top is it's got to be unexpired, no controlled substances. After that, it's pretty open. I'll say that the IV meds, so inpatient meds, are a little bit less able to be matched on the other end. So we're growing out more partnerships for entities that would be interested in having those and administering those meds. But outside of that, if it's a med that's room temperature, whether it's an injectable, a liquid, a pill, a capsule, those are all donatable. If there's ever any questions too, like it's one of those things where we'd rather folks reach out to us and have a conversation. So, even if we can't help today with that med, we are keeping a log of these things so that we know where to go into next. And like, hey, we should build out a system that allows these types of meds to be donated because there is surplus out there and we can find demand for it on the other end.
Okay. And I know Joe had mentioned the SIRUM website, which I actually found extremely informational. I really enjoyed looking through it and then learning a little bit about your company and the team. Is there anywhere else that you would mention that pharmacists or other facilities would go to find out a little bit more information, how they can get involved? I know you mentioned reaching out as well. Is that a better platform? What would you recommend to other healthcare providers?
Yeah, great question. Thanks for asking. So, our website is the best place. So it's just sirum.org. That's spelled SIRUM.org. You can also email me directly. So my email address is george@sirum.org. And we're happy to help out in any way and explore options to partner or just provide more education to anyone that's interested in this work.
Okay, great. Well, I know we're coming up on time here, so I just really wanted to thank both of you for sharing your insight and expertise today. I think it's really inspiring to see the collaboration between oncology pharmacists and a nonprofit's dedicated work that's paving the way towards improved healthcare for resource utilization. I think really the information that you guys both provided highlights the power of innovation in addressing this clinical need through medication redistribution. And clearly, you've shared some great stories. Joseph shared some great stories. I can think of a few more even now as we've been talking of patients that really need this support and otherwise would face some financial and barriers that just wouldn't allow for their care, or at least their timely care. I think Joe made up a really great point about even if they are able to get the medication, it may be a few weeks late, and that really can make a difference. So I really just want to thank you both for your time and sharing your expertise. And I'm excited. This is really great. And I look forward to maybe working with both of you a little bit more in the future and helping the program.
Thanks, Paul. And thank you, Joe, for the partnership. Thanks to HOPA. This has been wonderful.
I'd echo that. Thanks again for the opportunity to be able to share what SIRUM has been doing, how I've been able to assist them, and they assist me. And thanks again to Paul for providing us with the opportunity and guiding the conversation.
Yeah. Thank you, guys.